Hey, you guys, welcome back for another day of practice questions. As always, I like to get into my introduction and disclaimer before we get started with our questions for today. So, for those of you who are familiar with me, hey y'all. For those of you who are new here, welcome, welcome, welcome. I am Dr. Brittany Weinstock. I am a family nurse practitioner, and I am the founder and CEO of the Nursing Studio. I assist nurses as well as nurse practitioners with being successful on boards as well as in practice. I have been providing review courses, live, virtual, as well as books and tools and videos to assist nurses and nurse practitioners internationally with exam success since 2015. But, I always like to give my disclaimer that there's no absolutes in medicine. We treat on a patient by patient basis. And anytime that I'm providing questions, it is based on the guidelines that are currently being tested on the AAMP as well as the ANCC. If I am teaching on things that we actually do in practice, guidelines will vary slightly as tests are changed. So I will always tell you guys that in those videos so that there's no confusion, okay? But with that being said, let's get into question number one for today. Question number one states, the nurse practitioner has diagnosed the patient today with prostatitis. Upon examination, she noted he was negative for any STDs or STIs. Patient denies any known allergies. Based on these findings, how should the nurse practitioner treat? Is it A, ceftriaxone, B, rocephin, C, ciprofloxacin, or D, amoxicillin? Take a moment and tell me what you got in the comments. All right, you guys, I always recommend reading the stem of the question first because it makes you slow down a bit and stop and see if you're answering what is even being asked of you, right? So here it says, based on these findings, how should the nurse practitioner treat? And I always say, we study in the format of assessment, diagnosis, evaluation, and treatment. That's how I teach. That's how we practice. That's how we document. That's how they test you on boards. If you do any of my stuff, you know it. You know that's my soapbox, and you're probably tired of hearing it, but I promise, trust me. So here it's asking you how should the nurse practitioner treat. So you know what we do? We run it back, right? Because if we're looking for treatment, we have to have a diagnosis. In order to have a diagnosis, we have to have an assessment to lead to a diagnosis, right? So go back and look at what the assessment and diagnosis is. So here they already told you that the nurse practitioner has diagnosed this patient with prostatitis. The patient doesn't have any allergies. The patient was negative for STDs, STIs. So when you start to formulate this, we're thinking, how do you treat prostatitis, right? So you should be running through your mind of treatment options. We can do ceftriaxone. We can do Cipro, right? All these things are coming through your head, but you're trying to differentiate and find the best treatment option. So would it be A, ceftriaxone? Well, even though that's a treatment, it says here that the patient is negative for STDs and STIs. So you don't really need to use the ceftriaxone. When they are negative for STDs and STIs, you want to go with your ciprofloxacin, okay? Cipro and ceftriaxone can be utilized, but if they don't have STDs or STIs and that's not the cause, then we go the route of Cipro, okay? Because there's multiple things that can cause prostatitis, like a bacterial infection, a recent UTI, your STIs, if they had a prostate biopsy, all of this can cause that inflammation to the prostate itself. So you're thinking about the potential causes that have led us here. And since they are negative for STDs and STIs, we know that's not the route. But when it is, ceftriaxone is the best treatment because think about it. Chlamydia, gonorrhea, those are things that we can utilize to treat those type of things that could have potentially caused this. So you want to treat that underlying cause. So second thing, ceftriaxone and rocephin are the same medications. Again, make sure that you know your generic and brand names so you're not tripped up on things like that. But your best answer choice here is C, ciprofloxacin, okay? Because again, the prostatitis was not secondary to an STD or STI. All right, question number two for today. The nurse practitioner is reviewing the patient's labs. The patient is anemic, and additional labs show microcytic hypochromic, a normal ferritin, and normal iron. The patient states she is fatigued. What is the best diagnostic exam to assist in confirming this differential diagnosis? Is it A, a hemoglobin and hematocrit, B, a hemoglobin electrophoresis, C, an iron profile, or D, nothing, just to continue to monitor the patient? Take a moment and tell me what you got. Tell me what you have. Tell me what you have. All right, you guys, STEM of the question states, what is the best diagnostic exam to assist in confirming this differential diagnosis? So again, diagnosis, we take it back and we need to see what our assessment findings are. So this patient has anemia. Additional labs show microcytic hypochromate, normal ferritin, normal iron. So right there, let's stop before we go any further. So we know there's anemia already. Then when we look at microcytic hypochromate, think about my 2-1-2 rule, right? So with my 2-1-2 rule, and if you don't know it, go check out the anemia video to help you with that. It's just search anemia. I have it under my playlist too, under anemias and murmurs. So check that out if you need help with this. But I talk about a 2-1-2 rule because there's 5 common anemias, and the 2 that follow in that lower category of microcytic hypochromate is your iron deficiency anemia as well as your thalassemia, right? And then you need to know how to differentiate between the two. So with iron deficiency anemia, you know that the ferritin and iron levels are going to be low because you're deficient in iron. Whereas with thalassemia, the ferritin and iron are normal. So here, this is presenting more as thalassemia. So knowing that, you need to know how to proceed from that standpoint. So microcytic hypochromate, we have ruled out iron deficiency anemia because the ferritin and iron are normal. We have a differential of thalassemia because the ferritin and iron are normal, right? The patient is fatigued. Fatigue is common with iron deficiency anemia and thalassemia. But then you need to think of other things that you do to test. Now, the gold standard for thalassemia diagnostics is B, the hemoglobin electrophoresis, uh, commonly utilized for the beta thalassemia diagnosis. Oftentimes, patients already know about thalassemia early on with their symptoms, and it really doesn't require management unless they are symptomatic, and then they usually require like a lot of blood transfusions, things of that nature. But hemoglobin electrophoresis is the gold standard for that beta thalassemia. Remembering that thalassemia is commonly seen in Mediterranean populations, um, and it's typically like a genetic thing that has been passed, inherited to the patient. And again, for treatment options, we commonly, if they warrant treatment, it's commonly those blood transfusions, but you have to be very careful not to cause them to be in an iron overload because then they'll cause, other organ damage, liver, etc. So it's just a lot that goes with it. And I just went down a whole soapbox, but I know people have so much difficulty with thalassemia because it's not something that we commonly work with or see. So just want to throw that tidbit in there for you guys. All right. And then lastly, question number 3 for today. A patient presents to the office today during her summer break. She denies any complaints at this time. She has a history of COPD. FEV1 today is 42%. She currently takes Atrovent PRN and Spiriva daily. Based on these findings, how should the nurse practitioner treat? Is it A, you want to add in albuterol PRN? B, give a flu vaccine, send to pulmonary rehab, add in albuterol PRN and budesonide? Is it C, give a flu vaccine, pulmonary rehab, and budesonide? Or is it D, pulmonary rehab and Pulmicort? Take a moment and tell me what you got in the comments. All right, you guys, the question states, based on these findings, how should the nurse practitioner treat? So again, we're looking to treat it, so we need to take it back and see if we have a diagnosis. If not, looking at the assessment to get to a diagnosis. But here, we know the patient has a history of COPD. Her FEV1 is 42%. So that right there already says, all right, wait a minute. Where are we with treatment? Where are we with the therapy? 42% is the severe stage, stage 3, right? We have stage 1, 2, 3, and 4 in the gold COPD stages. Stage 1 being mild, stage 2 being moderate, stage 3 being severe, and stage 4 being very severe. And looking at the FEV1 helps you to gauge which one they're in, because think about it, the severe stage of 3 that we're in here, it just goes down. So it's anywhere in the mild stage, it's greater than 80%. In the stage 2 moderate stage, it's anywhere from 50 to 80%. In the moderate stage, it's anywhere from 30 to 50%. And then in the which is stage 3, the severe stage, sorry. And then the stage 4, the very severe stage, is less than 30%. So here, 42% falls in between 50 and 30. So we know that's stage 3 of the severe stage of COPD gold um, stages. And so then you need to know, how do you treat in each of those. Now, she's already on Atrovent, PRN, and Spiriva daily. So she already has a SAMA, a short-acting muscarinic agent, which is your Atrovent, PRN. She's already on a LAMA, which is your Spiriva daily, right? So what do we do next? Because if you go down the list in your mind, in stage 1, the mild stage, we have you on a SABA or SAMA PRN and the flu vaccine if it's flu season. All right. Stage 2, the moderate stage, we have you with your SABA or SAMA PRN. Throw in that LABA or LAMA. If it's flu season, give that flu vaccine and get them in pulmonary rehab. Stage 3, where we have a SAMA or SABA PRN, right? So we have that already. A LABA or LAMA, we have that already. Flu vaccine, if it's flu season, it's not flu season. They said she's here on her summer break, so we know it's not flu season. Flu season is anywhere from October to March. It's not flu season, so we don't need a flu vaccine right now. Pulmonary rehab, yep, we have pulmonary rehab in our rotation during this stage. And then you also want to add in an inhaled corticosteroid, right? So here, the only thing that really needs to be added is D. You're making sure she's in pulmonary rehab, and Pulmicort for your inhaled corticosteroid. Again, remembering both brand and generic names. Budesonide and Pulmicort are the same medication. C wouldn't be correct because we don't need the flu vaccine because it's the summer break. It's not flu season. Albuterol PRN is a short-acting beta agonist of SABA. We already have a SAMA. We don't need that. Again, and B, we don't need the flu vaccine. We don't need the SABA PRN, so you can eliminate that as well. So again, the answer is D, pulmonary rehab and Pulmicort. Just making sure she's in pulmonary rehab and adding in that inhaled corticosteroid. All right, you guys, I hope you found this helpful. When you are doing COPD, your asthma, look at it in a chart, write it out in a chart. I have videos on it to kind of help you so that you can break it down, see it. And this is one of those things, I always say repetition is the key to retention. This is one of those things that you have to have repetitively and seeing it and writing it out and reviewing it so that you can just easily go boom, 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 boom up the steps, right? Instead of saying, just getting all mixed up, and making sure as you're doing it, knowing the drug class and the medicines that fall into that category so that when you're in a scenario like this, you're able to process through. Okay. All right, you guys. But as always, be sure to like, comment, subscribe, and share with whomever you may think may find this beneficial as well. But make sure you meet me back here. We'll continue doing our practice questions daily. And if you need any of our resources, our review courses, our review book, or if you need a one-on-one session to help you with any of your weaknesses or to help you really structure your studies and go from being unsuccessful to successful on boards, reach out to the Nursing Studio. Give us a call at 803 400 6864 or shoot us an email at thenursingstudio, the number one at gmail.com. I have also added our website and links to other tools in the bio to help you with ease of access. But meet me back here, you guys. Happy studying. Bye, y'all.